go ahead and get started to give Christos as much time as he needs here to cover through his topic.
So you want me to introduce, which I'm happy to do. So from here from London, I'm happy to introduce my colleague Christos Bourantas to you. We've been working in close collaboration ever since I joined BARTS 4 years ago. Christos graduated in Greece. He is Greek, but ventured to the Torque Center in Rotterdam as a fellow. And that, I think, was the defining move. There he completed a PhD with Patrick Sarois, who at the time was sort of the Nestor, godfather of European, maybe global cardiology. So Christos joined the brotherhood there, which he still enjoys. He then moved to the UK and is now a honorary associate professor at UCL and Queen Mary University in London and a full-time interventional cardiologist. As you will see, his special interest is imaging and the use of artificial intelligence to make imaging better. He is leading a small team of fellows and collaborates with the engineers at UCL. But he's mainly practicing interventional cardiology and will focus on the practical side of things first, I'm told. So over to you, Christos.
Thank you very much for the introduction, Prof. I'm sure that all of us were convinced that intravascular imaging should be used on a daily basis in the catheterization laboratory. So the question is when to use intravascular ultrasound and where to use optical coherence tomography. And this is the topic of my talk. So in terms of lesion severity, I believe that there is robust data for IVUS, but not for optical coherence tomography. There are 3 studies assessing the efficacy of IVUS in detecting hemodynamically significant lesions, and in Caucasian, a cutoff of 5.9 millimeters square for the minimum lumen area, while in South Koreans, a cutoff of 4.5 millimeters square has been proposed. So we have also the LITRO study that was performed in Spain, which included 354 patients, which had revascularization when the MLA was below 6 millimeters square in the left main stem. And as you can see, there was no difference in outcomes between patients who had and those that did not have revascularization, suggesting that's a good, a reasonable approach for defining revascularization in patients with left main stem disease. So the recently published European Society of Interventional recommendation from the Intravascular Imaging Group has come up with this algorithm based on the existing evidence, suggesting a conservative management when the minimum lumen area in the left main stem is greater than 6 millimeters square. When the minimum lumen area is between 4.5 and 6 millimeters square, physiological assessment should be considered. But of course, there is a problem when you have tandem lesions about how to treat these patients. And when the MLA is less than 4.5 millimeters square, we have to perform coronary revascularization. IVUS is also a useful prognostic tool. We have the study coming from S.J. Park, which has demonstrated that if you have a minimum lumen area in the left main stem smaller than 8 millimeters square, in the Carina 7 millimeters square, in the lady 6 millimeters square, or 5 millimeters square in the left circumflex, then you have a high event rate at 2 years follow-up with a MACE rate reported up to 10%, while in case that you have no other expansion based on these cutoffs following revascularization, the event rate is less than 2%. What about non-left main lesions? We have performed a meta-analysis looking between IVUS and OCT in identifying flow-limiting stenosis. And if you pull all the data together, it seems that OCT is superior to intravascular ultrasound for identifying stenotic lesions using FFR as a reference standard. The limitation of the meta-analysis, we were not able to come up with a cutoff for both IVUS and OCT. Probably OCT is superior to IVUS because it has the ability to assess more accurately lumen dimensions. Another significant advantage of optical coherence tomography is the fact that it enables more accurate assessment of lesion length. And there is data showing that during the cardiac cycle, the IVUS catheter is moving within the vessel not only laterally, but also longitudinally because of the motion of the vessel, actually. So that results in displacement of the IVUS during the cardiac cycle, which has been measured up to 5.5 millimeters, while in a more recent study performed by Talou, the average motion of the IVUS catheter during the cardiac cycle was 2.4 millimeters. This can result, as it has been shown in a study published by a group of Professor Saraus, that IVUS used to overestimate a segment, and in this occasion the length of the PVS was used, while angiography tends to underestimate a segment of interest. On the other hand, optical coherence tomography has an excellent accuracy in detecting a segment of interest. And if you have accurate estimation of lesion length and accurate estimation of lumen dimensions, then you can implement computational modeling or use formula that has been created to estimate a pressure drop across a narrowing that has been incorporated in user-friendly software. We have the first software coming from the group of Sanven 2, and there's also work that's performed also from Abbott toward this direction. And you can see that the OFR software, this is how it was called, when it was compared to FFR in 143 vessels, had an excellent accuracy with an area under the curve of 0.93 in detecting flow-limiting lesions. This is a snapshot of the user-friendly interface of the software. There's a similar software also introduced for analysis of intravascular ultrasound imaging data. The name of the software is UFR, but as we discussed, since OCT enables more accurate evaluation of lesion length and lumen dimensions, I suspect that will be superior to UFR. Of course, this hypothesis has to be proven in future studies comparing the efficacy of these two technologies. So what about the value of intravascular imaging in understanding of coronary artery pathology? This is something that has not been appropriately studied because probably it's very difficult to quantify the value of intravascular imaging in this setting. While we're talking about graphs, I would suggest probably the use of intravascular ultrasound. This is a case example highlighting this. A 49-year-old patient with a previous history of bypass operation and percutaneous coronary intervention with a lima to LAD, who had frequent angina symptoms and arterial ischemia, came for an angiogram, had patent grafts to the RCA and the circumflex, and also patent lima to the LAD. But you can see, I'm not sure whether this projects well, there is a somebody can appreciate some haziness and possibly double lumen. Indeed, when we perform intravascular ultrasound to this segment, you can appreciate in the intravascular ultrasound pullback 2 lumens, a false and a true lumen. And actually, when we managed to get the patient notes from the procedure that he had in another hospital, it appeared that a guideline was used to advance the stent to the anastomosis, which has caused dissection. Having this information in mind, it was obvious that if we had to perform revascularization to the LAD territory, you have to go from the native vessel that has still antegrade flow. In addition, for left main stem, I also think that the intravascular ultrasound is superior to optical coherence tomography because it can assess ostial lesions and also can give you cutoffs that you can use to defer revascularization. This is a case example highlighting the role of intravascular ultrasound. 79-year-old patient with multiple comorbidities, troponin positive chest pain, who has been discussing the MDT and then down for a bypass, was listed for percutaneous coronary intervention. If you look at the angiogram, because of the catheter prolapses in the LAD, it's very difficult to understand what's happening in that ostium of the circumflex and also to see what is the separate origin of these two vessels, or there is a left main stem that will enable you to perform a bifurcation PCI. I tried to perform intravascular ultrasound with the optic cross catheter and the catheter prolapse because of the extensive calcification. So what are you going to do in this case? Change the catheter. You can use a Volcano, the Phillips catheter, the Eagle Eye, which is bulkier, but it has a longer segment over the wire and gives you increased pushability. And the information that you get by this catheter was very helpful in guiding our procedure. The Smith circumflex was disease-free. There was calcification, but it was a decent lumen. If we go to the ostium of the circumflex, there is a calcified plaque, which has an arc of calcium of less than 180 degrees, and it was a short segment, make us feel that the balloon angioplasty can be used in this setting, and we don't need to use the bulking techniques. In the left main stem, and there was a left main stem, there was calcification, extensive calcification in the origin of the diagonal, and also there's calcium in the body of the left main stem. Having this information in mind, it was very easy to plan our strategy. We perform node ablation to the left main stem LAD and culotte percutaneous coronary intervention to the left main stem LAD and circumflex. However, when it comes to the main coronary arteries, and you have a complex coronary anatomy, probably OCT is superior. This is an interesting case of a 65-year-old patient with troponin-positive chest pain, who has been admitted, who had this event in Turkey, and at that time point, he was treated conservatively. Since then, he had frequent angina symptoms, and he was listed for a coronary angiography, which demonstrated an obstructive circumflex and RCA, but a significant stenosis in the LAD bifurcation. He has also a good LV function. It was discussed in the PT and was decided to be listed for percutaneous coronary intervention. So the angiogram was challenging, understanding the coronary artery pathology. And as you can see here, there's a tight lesion in the proximal LAD involving the ostium of the first diagonal. So OCT I performed OCT, and you can see there's a disease-free mid vessel. This is the origin of the diagonal in this, indicated with this asterisk. In the next frame, you can appreciate that there's plaque prolapse that's causing stenosis of the origin of the diagonal. Then there is a significant stenosis immediately after before the diagonal, a double lumen here suggesting healed plaque rupture and a disease-free proximal vessel. So how you are going to deal with this lesion? It's quite complex percutaneous coronary intervention because wiring the diagonal is going to be challenging, and balloon predilatation will definitely cause an obstruction of the vessel looking at the OCT images. And therefore, OCT was quite useful for treating this patient. First of all, the minimum lumen diameter was only 1.6 millimeters, while we also know that there was a plaque prolapse here that did not allow predilatation of the lesion, as has been suggested for some cases by a paper published by the Bruce Zota about how to treat, how to wire challenging bifurcation lesions. The catheters like Fine Duo or Twin Pass that have a side wire to facilitate wiring of the side branch do not have value in this setting, because the second wire comes at a narrow angle, approximately 30 degrees. Therefore, here would not have been useful, considering also that it was coming at an angle. The other approach that has been proposed was to use to knuckle the wire down, pull it back, and try to wire the side branch. That would not have been possible because you have significant stenosis proximally, and this can cause plaque disruption. So then the only approach left was the use of angulated microcatheters. And if you go to the ventral microcatheter, this has a diameter of 4 millimeters. And in our case, the maximum diameter that we have distally was 3 millimeters. So ventral microcatheter could not be used. Therefore, the only option was the supercross microcatheter, which has an angulation of 420 degrees and distal tip to the vent 3.5. In addition to that, the soft catheter, and therefore it's less traumatic to the vessel. Having this in mind, wiring of the lesion was very straightforward, with a hydrophilic wire in support of the supercross. And of course, the procedure was completed by performing DK crash so as to not lose the diagonal, which was difficult to be wired. There are, however, occasions that IVUS should be preferred when we have challenging anatomies. This is a case provided to me by Akiko Mehara. He's a 65-year-old patient who was presented with a non-STEMI. He had a history of PCI to the circumflex and RCA. And as you can see, there is significant disease in the proximal LAD. IVUS demonstrated a diameter of 4.5 millimeters. The lesion was predilated with 4 millimeters balloon. And you can see that there was progression of the stenosis more distally to the mid vessel, and flow was lost. So OCT should not be used in this setting because you have poor visualization of the vessel, and therefore it's very difficult to understand vessel wall pathology. IVUS was preferred, and this is a longitudinal section of the IVUS imaging. And you can appreciate that as you are coming back, there was an increased echogenicity area indicating hematoma, intramural hematoma that compress the lumen, resulting in significant stenosis. And if you know that, you know how to treat this patient. This is the flap that connects the true with the false lumen. You know, first of all, that the flap is coming after the origin of the left main stem, so you don't worry about having propagation to the circumflex. You have to use a stent more distally to cover to stop the propagation of the hematoma, and you can put a stent back coming to the ostium of the lady without worrying so much about the left circumflex. So this is in acute coronary syndrome. On the other hand, optical coherence tomography seems to be superior to IVUS because it can detect more accurately plaque rupture, plaque erosion, and erupted calcific nodules that are the most common causes of acute coronary events. However, and this is a case example which highlights the use of intravascular imaging in this setting. This is a 57-year-old patient who was admitted with a single episode of chest pain. The ECG did not show any significant abnormalities. There was of not right band branch block on the ECG. There was mild troponin rise. It had good LV function on the echocardiogram. This is his angiogram. As you can see, there's no significant stenosis, apart from minor plaque probably in the bifurcation of the lady with the diagonal. There is a study that has been published, the famous non-STEMI study, which imaging doctors do not believe in that, I have to admit, which showed that you can use physiology in order to defer revascularization. And if you do QFR, we did QFR just for our interest, you can see that there was no significant stenosis both in the lady and the diagonal. So do you leave this segment untreated? No. OCT was performed, and and as you can appreciate, in the proximal lady, there was no significant plaque. However, there was a thrombus just before the bifurcation, suggesting plaque erosion. And there is significant stenosis here, which according to the erosion study, should be stented. At the bifurcation side, there was no significant stenosis. Coming more distally, the vessel is disease-free. However, the diagonal, as you can see here, has a significant narrowing. Having this information in mind, planning the procedure was straightforward. We performed in this case Coulot PCI, which was assessed by OCT. And as you can see, we have excellent, not only angiographic, but also intravascular imaging results that satisfied the proposed Illumin 3 criteria. This is another case example which highlights the value of intravascular imaging. This is a 67-year-old female who was admitted with shortness of breath, some ECG changes, and troponin positive. He has history of COPD and hypothyroidism. And when we did an angiogram, there was a hazy lesion that was very difficult to understand what was happening here in the mid-RCA. However, OCT was very helpful. As you can see, there is a honeycomb appearances in the lumen suggesting recanalized thrombus. So probably there was a thrombosis of the vessel that led to an acute coronary syndrome, and then there was spontaneous recanalization, restoring the flow to the distal vessel. Having that in mind, it was clear that we have to proceed to percutaneous coronary intervention. OCT is also very useful in order to differentiate recanalized thrombus from a woven coronary artery, which is a congenital disease. And as you can appreciate, the appearance is very, very similar. The management is not necessary. Percutaneous coronary intervention in this setting can be just an innocent bystander in coronary angiography. And the only way to differentiate these two pathologies is to look carefully in the flaps separating the different chambers. And in the woven coronary artery, there's a clear appearance of the media, and suggesting that there is something that is congenital. While in the other occasion, in the recanalized thrombus, it's just thrombus that separate the different channels. There are occasions, however, that IVUS should be preferred to optical coherence tomography. And this is an interesting example of a 53-year-old patient who had a history of right-sided squamous cell carcinoma that has resulted in metastasis to cardiac metastasis, and was admitted with a STEMI. He had a CTCA 2 months, which showed the myocardial metastasis, compressing but not causing obstruction in the left anterior descending coronary artery. He came with a chest pain, anterior elevation, and this is his angiogram. The LAD was blocked. I mean, it seems straightforward to take a balloon and start ballooning it, but the challenges that you have to have, the things that you have to think at that time point is whether there will be a risk of complication. It is likely that the vessel wall may have been infiltrated by the metastasis, and therefore ballooning may have caused perforation. And also you need to know how much of the vessel is compressed by the tumor. The intraoptical coherence tomography cannot be used in this setting because there is complete flow obstruction and you have to balloon, which is something that you don't want to do without knowing the coronary artery anatomy. Therefore, IVUS was performed, and you can see that in the distal vessel, there's no significant compression, and there is no plaque in the left anterior descending coronary artery. Coming to the mid vessel, there is a compression of the left anterior descending. More proximally, the vessel is disease-free again, and there is a short segment of compression, as you can appreciate. And this is another cross-section close to the diagonal that indicate the disease-free vessel. So POBA was performed with excellent angiographic results. Prognosis was poor. We did not want to give him aggressive antiplatelet therapy for a long period, and we stop here. MRI has demonstrated progression of the cancer, and the patient, of course, had a poor prognosis. But a good recovery from his coronary event. This is another case example highlighting the value of intravascular ultrasound. A female patient coming with anterolateral STEMI. She had multiple episodes of chest pain and vomiting. She had a history of hypertension with baseline creatinine of 95 millimoles per liter, but when she was admitted, it was 240. So she had an acute kidney injury. Echocardiogram demonstrated anterolateral hypokinesia, and as you can see, there are 2 lesions in the LAD and the diagonal. The question is which you should treat in order to relieve patient's symptoms, and of course, physiology, I don't believe would be again helpful in this setting. However, if you do EQFR, the flow-limiting disease was the LAD, and the diagonal seems to have no significant stenosis. Nevertheless, this kind of approach would have led to complication. If you look at the intravascular ultrasound imaging, there is no significant stenosis in the mid-LAD. Coming back, however, there is an attenuated plaque, lipid-rich plaque, which cause flow obstruction. This also is a diffuse disease, as you can see from this cross-section at the septal, while at the bifurcation side, there is diffuse concentric atheroma, diffuse concentric atheroma. Looking now at the diagonal, there's disease-free distally, but more proximally, there's a tight stenosis. I could not see a plaque rupture in this pullback. And also at the ostium of the diagonal, there was the significant stenosis. The proximal LAD has no significant plaque. So if you have decided to proceed to PCI with the LAD, it would be clear that with this coronary anatomy would have had plaque shift, but also stenosis at the diagonal. We have to rewire, we have to perform ballooning, and we're very unlikely that we'll be able to have an optimal result in the diagonal as there was diffuse disease throughout. So having that in mind, PCI was very straightforward. We stented the middle AD with a 2.5/20 stent. We ballooned the diagonal. We anticipated that we have a problem with that. We then deploy a stent, 2.75/23 millimeter stent. Then we bought so as to have no difficulty to rewiring, and then we use the stent boost approach. I don't have these images, but you can appreciate by having the stent boost, you can easily see where the dot of your stent is in relation to the other stent implanted in the LAD. We do not have to inject contrast. We performed final kissing and pot, and this is the final results. And I had to do coronary angiography. I would have stopped with IVUS, but I had to do 2 times coronary angiography because the blood pressure of the patient dropped, and I was worried that he had a possible perforation or we lost flow. Eventually, what has happened is that he has a vasovagal attack twice. In total, the procedure was completed with approximately 100 elements of contrast, of which 70 has been used for the coronary angiography, as there was aberrant circumflex, it was very difficult to get diagnostic images. And there are data supporting the use of IVUS in kidney failure. There's a motor study which has demonstrated that if you use IVUS, you're using less contrast, but that takes more time. And there's also a study coming from Ali and the group of Columbia suggesting that you can perform with intravascular ultrasound percutaneous coronary intervention with zero contrast. In stent failure, however, OCT should be preferred because it can identify more accurately causes of stent failure, such as non-overlapping stents, stent fracture, edge dissection, plaque at the end of the stent, presence of thrombus, which can cause thrombotic stenosis, and stent under expansion. Moreover, in terms of stent thrombosis, again, I would suggest the use of optical coherence tomography because it can identify more accurately the most common causes of stent thrombosis, such as stent under expansion, strut malapposition, evagination, rupture neatherosclerotic plaques, plaque at the stent edge, and edge dissection. So this is the value of IVUS and OCT for assessing coronary pathology. What about the role of these two techniques for guiding revascularization? When you have stent failure, the information provided by OCT can guide treatment. If you have plaque at the stent edge or a dissection, a drug-eluting stent should be implanted. If you have stenosis, we need to assess the neointima, and depending on the type of the neointima, you can use either drug-coating balloon or drug-eluting stent. In homogeneous and layer neointima, you can get away the drug-coating balloon based on the data that we have. If you have heterogeneous or lipid-rich neointima, drug-eluting stents should be preferred. If you have a calcific neointima, you need to make an effort to optimize lesion preparation, to have optimal lesion preparation using should be considered. For non-overlapping stents, another drug-eluting stent should be implanted. If you have stent fracture, drug-coating balloon and drug-eluting stent seems to be equally effective. When you have multiple layers of stents, brachytherapy or drug-coating balloons should be preferred. What about stent thrombosis? Again, OCT seems to be superior to IVUS because you can detect more accurately the presence of malapposition and also edge dissection. And when you have these pathologies and stent artery expansion, when you have malapposition and stent artery expansion, plain old balloon angioplasty should be considered. If you have evagination, which is a response, inflammatory response of the vessel wall to the implanted stent, then again, you should avoid implantation of another stent, and POBA should be performed, while in case of edge dissection, plaque at the edge of the stent, and atherosclerosis, drug-eluting stent should be implanted. The data supporting the use of IVUS in native coronary artery disease for guiding revascularization are overwhelming. This is a meta-analysis coming from the group of Chen, which included only randomized studies, which has showed that a lower IVUS is associated with a reduction of MACE, a lower incidence of target lesion revascularization, a lower risk of cardiovascular mortality, a lower risk of stent thrombosis, and there was a trend towards a lower incidence of myocardial infarction, although this did not reach statistical significance. And we're talking about a hazard ratio for approximately 0.6, suggesting that you have 40% lower incidence of events with the use of intravascular ultrasound based on the data from studies. This is much, much higher, the protection that you're getting by IVUS comparing to the use of statins, which we're recommending now in all our patients. What about the data supporting the role of OCT? There is only analysis of registry data that has come from our group indicating that OCT is associated with lower incidence of events. After doing propensity, this is a Kaplan-Meier without propensity matching. After doing propensity matching, IVUS and OCT seems to be equally effective in reducing MACE, and this was attributed, and we also noticed a lower incidence of MACE during the hospital admission. There are two studies, as we have already said, the Illumine 3 study that has completed patients' recruitment, and we're anticipating the results from this study soon, that aims to examine the value of OCT in improving outcomes in high-risk patients. And we have also the October study that is a study dedicated in bifurcation lesions. If we try to compare the value of IVUS and OCT for guiding revascularization, the data indicate that IVUS is superior to OCT for stent sizing. You can decide, you can use, it seems that we have the tendency to take large stents when we use IVUS for guiding revascularization. This at least is supported by the European study. In terms of malapposition, IVUS OCT seems to be superior to IVUS for detecting malapposition, as it has been shown by the Illumine 3 study. It's also superior to IVUS for detecting major dissections, while when it comes to the presence of thrombus, the Illumine study showed no difference, the Illumine 3 study. However, I would suggest use of OCT. I'm sure that you can see better with optical coherence tomography. For detecting plaques at the edge of the stent, which is the last common cause of stent failure, IVUS and OCT seem to be equally effective. In bifurcation lesions, OCT should be preferred comparing to IVUS because it enables assessment of the bifurcation angle, and there is a dedicated OCT software that has been designed for this purpose. It's the QCQ CMS software. It can facilitate rewiring at the distal cell of the stent, and there is data supporting that you have less malapposition with this approach and better hemodynamics. Yossi has published a study recently, and the results have been shown at EuroPCR. You have less malapposition and better hemodynamics. You go to the distal cell. And if you like to see the carina or plaque shift in the final results post-dilatation of not OCT, OCT is an excellent modality. In CTOs, seems to be IVUS the ideal technique, can facilitate wiring stumpless CTO, identify the ideal location for reverse card, identify connection, facilitate wire externalization, can facilitate antegrade reentry and retrograde reentry. So summarizing, I suggest that IVUS should be preferred for assessing left main stem lesions, for assessing ambiguous angiography in left main stem, ambiguous coronary anatomy in left main stem, for assessing vessel pathology in grafts, and in cases that we have complete flow obstruction, such as external compression or intramural hematomas. Moreover, IVUS seems to be better to OCT for stent sizing and for guiding PCIs in patients with chronic total occlusions and in patients with renal failure. Conversely, OCT should be preferred over IVUS for assessing lesion severity in non-left main stem lesions, when especially we have in our catheterization laboratory tools like the OFR that enables estimation of the pressure gradient, taking into account not only lumen dimensions but also lesion length. Can be used for assessing ambiguous angiography in patients with suspected acute coronary syndrome. Identify causes of in-stent stenosis and stent thrombosis and guide therapy, guide percutaneous coronary intervention in bifurcation lesions, assess the final results post-PCI and detect the presence of thrombus, malapposition, edge dissection, and guide therapy. A few words about the future of intravascular imaging. I believe that it is likely it's used to increase in future because there are more new software that are likely to become available that will enable more accurate assessment of vessel wall pathology, comprehensive visualization of different tissue types. There's work from Abbott towards this direction, quantification of the final PCR results, and guidance of further therapy. There's also research in standalone intravascular imaging, and especially in optical coherence tomography. The group of Brett Buma has developed the polarized optical coherence tomography that enables analysis of the polarization of the reflected OCT signal and more accurate quantification of characterization of different tissue types, and also quantification of the content of the fibrous cap, which is a feature of increased vulnerability. This approach is also likely to enable automated quantification of different tissue types that can be useful for guiding therapy. In guiding treatment. There's also a very interesting research happening at Harvard by Gary Turney, who has developed micro OCT. This is something that we are likely to see in the near future. There is a catheter for intravascular imaging that has been tested in animals, and this has brought down the resolution of OCT from 15 microns to 1 micron. And if you have this kind of resolution, you can see the leukocytes, or not only the leukocytes, but also the pseudopods that are connected to the vessel wall. You can see here monocytes are trying to invade through the endothelium to the vessel wall. You can see the presence of cholesterol crystals, but also you can see how a cholesterol crystal penetrates the fibrous cap, which establishes cause of an acute coronary syndrome, and you can see more accurately the presence of thrombus. There is also a lot of research in hybrid intravascular imaging, and there is an effort to combine different intravascular imaging techniques for more accurate characterization of vessel pathology. And there is a combined IVUS OCT catheter that has been designed recently and has first-in-man studies. This is the catheter of Coronary, and there is a catheter that is going to be available in the near future by Terumo. This is a snapshot of the user-friendly interface of the Coronary system, and this is a snapshot of the Terumo system that enables for registration of the OCT and the IVUS images in a hybrid image, and you can use this information combined with integrated backscatter analysis, a technique developed for characterization of the composition of the plaque in IVUS to characterize more accurately vessel wall pathology. This is a pullback with the Coronary system before and after percutaneous coronary intervention, and you can use pre-standing IVUS to define the location that you have to the proximal distal reference segment. OCT enables more accurate detection of the dissection before standing, and this is the distal reference segment. You can use this information to size your stent, and post-standing, you can use OCT to assess vessel wall pathology. There is more thrombus here that has not been detected by IVUS. There is also some malapposition here that has not been detected by IVUS, and also further thrombosis in this location that can be seen only by OCT. We have also the combined near-infrared spectroscopy IVUS catheter that has been tested in the prospect study. It seems to be capable to detect vulnerable plaques, and there are developments towards a combined near-infrared spectroscopy optical coherence tomography imaging catheter that will enable more accurate characterization of the cap thickness and of the plaque composition. And this is a typical example. You can see a low attenuated plaque here that lights up on near-infrared spectroscopy, indicated that this is a lipid-rich plaque. You can see another plaque with exactly the same morphology that does not lights up on near-infrared spectroscopy, suggesting that this is a calcific plaque. And this is a case that was given to me by Jim Miller, who is the inventor of this approach, highlighting the value of having both information about the cap thickness and about plaque composition for detecting vulnerable lesions. There are multiple plaques here which are lipid-rich. However, the one that causes event is the one with a cap thickness of approximately 40 microns, indicating that the thickness of the cap is of utmost importance in identifying vulnerable plaques. We have also the intravascular photoacoustic imaging, which relies on the analysis of the acoustic signal created from the thermal expansion of tissues after this being irradiated with light. And this approach can be combined with IVUS for more accurate characterization of the identification of lipid tissue. And finally, we have near-infrared fluorescence imaging, which relies on the injection of activatable markers that bind molecules associated with plaque pathology and have the ability to fluoresce when they are irradiated with near-infrared light. There are several tracers that has been developed for detecting vulnerable plaques, and there is one tracer, the FTP11, that can detect fibrin. Fibrin is something that often can be believed that is actually endothelization of the struts. There's a study that has demonstrated that in rabbits, and I believe that if you use near-infrared fluorescence imaging, as it has been shown in the DETECT OCT study, you can assess more accurately stent endothelization and stop antiplatter therapy earlier that is actually suggested in patients who are at high risk of bleeding. Finally, we have the time-resolved fluorescence imaging that relies on the assessment of the fluorescence emission decay time after molecules are being excited with pulsed light. And this technology can detect the presence of elastin, collagen, lipids, and also macrophages, as has been shown in a recent report, and it is believed that will enable more accurate detection of the vulnerable plaque. What, however, I anticipate to see in the future, I'm closing with this, is that it is very likely to combine not only imaging for assessing vessel wall pathology, but also computational fluid dynamic analysis for assessing vessel physiology. There are plenty of data showing that vessel wall response depends on the shear stress distribution. And the shear stress distribution is very abnormal in the coronary arteries because we have complex geometries. As you can see here, after most stenosis, in the proximal AD and the curvature in this location, there are flow disturbances resulting in low shear stress that are being sensed through mechanotransduction pathways, regulate vessel wall biology. This is a case example highlight this in stent failure. This is a patient that the case was provided to me by Dr. Guagliumi. This is a patient who was admitted with an acute coronary syndrome, had percutaneous coronary intervention to the RCA. This is the OCT post-procedure. Somebody can argue that it's excellent results. There's some malapposition in the inner side of that curve because there is some ectasia of the vessel. There was a good stent expansion and the vessel was left untreated. This patient came back 4 months later with another event. And as you can see, there is extensive thrombosis in the inner side of the curve in this location, and local shear stress distribution was performed. You can appreciate there is very few vectors passing through the stent struts indicating flow stagnation. This can be appreciated better in this view where you can see low shear stress indicated with blue because of vessel ectasia. And if we look at the vectors of the blood flow, we have recirculation zones here and areas of high CR rate and areas of low shear stress. And high CR rate, which is the difference in the velocity between different layers of blood, seems to activate the vulnerable factor that's activated further in low shear stress environment. One moves further down to a low shear stress environment, and this is the way it unfolds. It attracts platelets, leading to thrombosis. I believe that this is computations that can take a lot of time today, but machine learning carries a great promise, and it is likely that we have approaches to have a quantification of the shear stress distribution after intravascular imaging with definitely an OCT modality. You can have IVUS as well for assessing this and predict more accurately events. Thank you very much for your attention.
Thanks, Christos. That was quite a review. Very impressive. I wanted to ask you a practical question, if I could, and that is the question of identifying landing zones. So I think one thing that ends up being very confusing sometimes when you use imaging is to decide the size and length of your stent. And, you know, I think studies like the Ultimate trial, which came up with definitions of what your landing zone should be, are very helpful. Can you just give us your perspective on when you look at a very diffusely diseased artery, how you choose your landing zone and then how you size your stent based on a very diseased artery?
Yeah, I believe that the Ultimate study and also the IVUS XPR are very important studies highlighting the value of intravascular ultrasound. In my mind, however, they had a significant limitation. The limitation of both studies is that they have a very, in a way, flexible criteria for defining optimal stent deployment. I believe that we should take full advantage of the intravascular imaging and be by far more aggressive. And for this purpose, whenever I'm doing a PCI, I'm trying to stick with the Lupin 3 criteria, which in a way push the bar quite high. Of course, we have to accept that heavily calcified lesions, you cannot get a stent expansion of 90%. You can probably compromise with 80 or 70%. But we should try to have an optimal PCI result using intravascular imaging. In terms of size, in terms of defining the edge of the stent, there is data suggesting that you have a plaque burden at the edge of the stent more than 50% for a length of 5 millimeters to 10 millimeters, depending on the studies, then the event rate is higher because of edge-related edge-related events. So if you have diffuse disease, then it's a clinical judgment. It's very difficult to, you decide based on the lumen dimensions where you have to stop by implanting a stent. But if you can find a segment with a plaque burden less than 50% in the proximal and distal to the lesion, and then I would suggest to use this one for stent implantation.
Thank you.
Christos, it's Mike.
Yes.
This is just an opinion, but if you look at the studies with triple vessel disease and comparing CABG to angioplasty, do you believe that if we used IVUS, imaging guided PCI, that the differences at 5 years would be significantly narrowed?
I believe that this is a very good question, and I think it's a great opportunity for another study, and why don't we do that together? We have data from the Excel study showing that the event rate is much, much better, and we have also the Syntax 2 study suggesting that if you use intravascular ultrasound imaging, you have a better results for guiding your procedure, you have a better results than guiding your procedure using only angiography. The question is, I think what the centers are very good at is that they bypass the proximal segments. And there are some patients that are this patient with 3-vessel disease has a very extensive atherosclerotic profile. And the risk of neointima formation is going to be very high. And the risk of occlusion in some of these vessels because of neointima or for any other reason of disease progression, a little bit distally to the stent or more proximal to the stent is high. Nevertheless, there is a population that probably will do equally well or even better by having, and even in diabetics, I believe, by having a PCI, for example, those with a low Syntax score. And a Freedom study based on the data we have from the Freedom study, all these patients with 2-vessel disease are referred for percutaneous coronary intervention. It's very difficult to define which of them are going to do better using Syntax score probably. But I'm sure that some of our patients that are referring now based on the recommendations for bypass may have done equally well or better if they had intravascular imaging guided PCI.
Do you think a new score is appropriate using OCT and IVUS data to determine what the best option is? In other words, do you think, I'm not suggesting that we image everything, but when we image, are there parameters from the IVUS or OCT that may make you lean one way or the other?
In terms of, you mean in terms of sending the patient for a bypass or sending the patient for a PCI? Yeah?
Yes.
Yeah, that's a very good question. That is a very good question. We know which lesions are going to cause us problems. Calcific lesions is definitely the one that we have some challenges in getting optimal PCI results, and especially if you have a ring of calcium more than 180 degrees, a thickness of more than 500 microns, and if I remember well, based on the study coming from the group of Akiko, should be 3 millimeters the length of the calcification. This is some criteria for deciding whether we are going to use a debulking technique or to use balloon predilatation. Bifurcation lesions, the high event rate, but again, we have not don't have evidence for bifurcation lesions that OCT is associated with better outcomes. October study may answer this question. The data for bifurcations for intravascular imaging are not there yet. And the data for also for acute coronary syndromes for intravascular imaging do not exist. We have data for long lesions that improve outcomes with a left main stem. And we have that's the lesion that we have the most of the data today. I'm not sure what will be the criteria for deferring revascularization based on intravascular imaging. It's very difficult to quantify that, isn't it?
Christos, I have one other question about OCT. Do you often use either dextran or saline to do your imaging, especially in people with renal dysfunction?
No, we don't have that, and I would very keen to use it. We don't have that in our center, no. But it is something that we should bring here.
Yeah,
do you have it? Do you have it in Yale?
Yeah, we've used dextran successfully, and anybody who has any renal dysfunction, we default to dextran for doing the OCT imaging, and it really, I think, you can get equivalent images for sure. So.
And what about the quantification, the dimensions? There was some, I think there was some question about how accurate is the evaluation of vessel dimensions using dextran, or the oversize or other size. Do you have any idea about this, or you think that's equivalent?
I've seen the publications which suggest that dextran alters your magnification and measurements can be thrown off. But practically speaking, I haven't been surprised at all when I do the OCT with dextran. And I don't think that there's a demonstrable difference clinically, but I have seen that data, yes.
Hey, Christos, this is Alexandra. Can you talk a little bit about the development of the OCT and physiology combined catheters? You're probably aware of the work that Tu and William Wines, et cetera, have been working on. Where do you see that going?
So in terms of profit, is that about hybrid intravascular imaging?
Yeah,
At this time point, William Wins and Tu are working mainly in software development, and they have introduced recently a paper published in Intraversion using experts to train machine learning algorithms to perform automated characterization of plaque composition in OCT. I know that there's also Abbott is working on that, and they have developed a software for characterizing and measuring the calcification. In terms of catheters, we have the combined IVUS OCT catheter, and there is already one that has clinical applications, and we're about to start the study here as well. Coming from Coronary, there is a study, there is one that's expected to become in the near future coming from Terumo. There's also research happening in California, and I think there's also Brett Buma is working towards a hybrid IVUS OCT catheter. There is a catheter coming from the group of Jim Miller, working with Gary Turney and Greg Stone to develop a near-infrared spectroscopy OCT catheter. This is the one that I have shown in a few slides before, that is expected to enable, they believe that's going to be expected to enable more accurate characterization of vulnerable plaques, because you have an assessment of the thickness of the cap and also of the presence of lipid. Near-infrared spectroscopy will give you the lipid, OCT will give you the cap thickness. There is also a catheter coming from the group of Farouk Jaffer, that the FLIM, near-infrared fluorescence imaging OCT catheter. This is a catheter that was developed in 2012, and they have done a first 3-month study. They believe that they will be able to detect more accurately vulnerable plaques by assessing vessel biology. And also they believe that they can detect more accurately endothelialization of stent struts. We're anticipating first-month studies in the near future with activatable markers. They have done a first-month study measuring the autofluorescence of the vessel wall, the fluorescence of the vessel wall without using the markers, and they seem that they provide some information about plaque vulnerability. They are going to introduce markers for assessing specific molecules associated with plaque biology in the near future. And also there is some research towards developing a time-resolved fluorescence imaging OCT catheter. I do not include that slide because of the space. Have not had first-in-man studies yet. Time-resolved fluorescence imaging has the challenge that it has to be very close in a way, can assess only a vessel with dimensions, can go only 250 microns into the plaque. So it has very limited penetration. There is a design for that has been introduced for time-resolved fluorescence OCT imaging, but I have not seen any big studies in animals or in humans yet. So there's a lot of work towards this direction.
Okay, wow. So a lot of stuff coming down the pike. I just thought that the combination of imaging with physiology is a good concept, right?
In terms of imaging and physiology, we have the software that they are doing, the UFR, the OFR. There's also one coming from Abbott towards this direction, having physiology or combined with OCT. And this is validated now in the fusion study. So there is a lot of work toward this direction. And I believe that this is better than using just physiology, at least in obstructive coronary disease.
Yeah. Thank you, Christos.
Thanks, Prof.
Christos, thanks a lot for that great review. You had some really, really great slides and great images. It was really exciting to watch. So thank you for being part of this.
Thank you for inviting me. It was a pleasure. It was really a pleasure. Thank you for inviting me.
Awesome. Great. Have a great day. Okay.
Bye.
Thank you.
Bye-bye.
Thank you very much. Have a good day on.
Bye-bye.
Bye.
That's good.